All right, good afternoon, everyone. I hope you're well, depending upon where you are. Good afternoon, good evening, or good morning. Most of you probably good afternoon. So I'm Dr. Patrick Lockwood, coming back to you live to do another kind of science and wellness talk. I hope that the last couple of weeks have been good since I last spoken to you guys. So this week there's not as much going on in terms of things I need to share, housekeeping, as Sam Harris would say. Just basic stuff. I'm waiting on the go date from the publisher about the book. So I don't quite have the release date yet, but as soon as I have that, I will blast it out on social media for you guys. So there's that. Second book is coming along. And it seems like that things are moving pretty well in the whole publishing, writing, researching world. But let's get to today's topic because it's an important one, it's a deep one, it's a complex and messy one. And I won't necessarily do it justice, but I want to give everyone kind of an introduction at the very least. And then maybe we can come up with some future topics, or I can come up with some future topics that we can talk about. So today's topic is trauma. And this is a really common word that people toss around. You hear it a lot nowadays with regard to people yelling at each other about politics. They're traumatized. You hear it with the Me Too movement. You hear it with the social justice warrior people. You hear it with angry conservatives. You hear it with liberals. You hear it with pretty much every group of people on the planet who thinks they have been hurt by some other group or some other person will at some point probably say it's traumatic what's happened to me. And this is maybe partially true, but also not really intellectually honest. And that's why I wanted to bring this up as a topic, because what we think of when we say the word trauma is not necessarily what trauma actually is, which is a common thing that I say whenever I do one of these live talks, is that we have kind of a colloquial version of a word, and it's one that we think is true, but it's not really true. And then there's a more scientific or technical definition based upon, in my case, the psychological research. And it'd be better if we started using that to talk about our life experience, because the research is the best place to go there. The science is the best place to go there. So just want to put that out there. Being offended doesn't mean you're traumatized. Being hurt doesn't mean you're traumatized. I'll actually talk about what trauma is specifically here in a little bit. And then there are also just a variety of issues in the professional world, in the medical and mental health world, in terms of what is actually trauma and what trauma diagnoses should or should not exist. So the difference between being traumatized, as in, having experienced the trauma, compared to actually having a disorder as a result of the trauma, those are different worlds. Because many people, in fact, as you'll hear later, a large majority of people who experience trauma don't actually develop a trauma disorder as a result of that. So we'll talk about that. And then there's this big debate in my profession and in multiple professions that are related to it about which are trauma disorders and which are not. Is borderline personality disorder a trauma disorder? Is there something beyond PTSD? So a brilliant guy out of Boston named Bessel van der Kolk came up with a bunch of trauma-based disorders for childhood that totally kind of go beyond what PTSD can handle as a diagnosis. So there's a lot of debate in academia about what really are appropriate trauma diagnoses and what disorders really kind of are due to trauma and not. And the final reason I wanted to do this talk, outside of clearing up all that political bullshit and kind of getting us a better definition, is people who've experienced trauma typically have some kind of change in how they function. And it's important to know what that is, why that is, and how to kind of heal after that happens. So I want to try and give you some very practical tricks at the end if you have experienced the trauma or you know someone who has experienced the trauma, which should be all of you, and how to help, how to make life a little bit better. And you know, trauma affects everything. It affects our sleep, it affects our mood, our ability to think, our ability to work, especially if it results in some kind of diagnosable condition like PTSD, for instance. So that's the introduction as to why we're talking about this, why I'm talking about this with y'all. So basically for the last, I would say 30 years, to define trauma, it's been kind of confusing because everyone in psychology, psychiatry, and in the research world is really kind of warring, kind of fighting about which definition of trauma is correct. And, you know, obviously this stuff goes back to World War II and all the research on PTSD and shell shock and stuff like that. And even before that, you know, our good friend Sigmund Freud wrote about trauma, kind of discussing it more as the outgrowth of the death instinct. So he really first discussed it in Beyond the Pleasure Principle. And he described it as some kind of desire to reestablish a state of things that was disturbed by the emergence of life. That's the death instinct, or thanatos. And that trauma basically activates our death instinct, as it were, according to Freud. And it activates our self-destructive behavior, hyper overwhelmed experience, compulsive behavior response, kind of as Freud would have thought about. And as you'll see as I talk about the actual research and the kind of legitimate scientific theory, not just Freud's musings, you'll see that he was kind of half right and half wrong. People who have experienced trauma do develop self-destructive behaviors, kind of like the death instinct, due to both shame, kind of a sense of I'm bad, I deserve to suffer, which is similar to thanatos, the death instinct, as well as due to neurological dysregulation wherein the brain is stuck in an incomplete loop, like a record or a CD that's skipping over and over again and can't quite finish the song, due to the disintegration of the traumatic memory into our self-story and our sense of personal bodily safety. That's a lot I said right there, and I just want to differentiate that I'm not saying Freud was brilliant or right or perfectly correct, but he's got some intuitive kind of stuff going on there well before we knew anything about the brain, well before we knew anything about how trauma overwhelms and creates this incomplete feedback loop in the mind. He had some good instincts. He had some really good instincts about how human evolution shaped the mind and compulsive behavior, especially with regard to self-destructive behavior. So what really is trauma? So we've got two choices here. Trauma can be defined according to the American Psychiatric Association's DSM-5. That's the diagnostic Bible of psychologists, psychiatrists, and medical professionals everywhere. Or we can talk about it from the more relational or attachment perspective, more slightly neuroscience informed. So the old school DSM-5 definition, and I say old school because it basically hasn't changed in a number of years, like decades. They say trauma is this. Trauma is having been exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in the following ways: direct exposure, witnessing a traumatic thing, learning that a relative or a close friend was exposed to a trauma, indirect exposure to aversive details of a horrific, life-threatening, violent incident in the course of, you know, a job role, like being a first responder as a paramedic and seeing someone dying. So basically the DSM-5 definition is being exposed to life-threatening or perceiving something as life-threatening issues, behaviors, experiences, or threatened sexual violence, etc. So basically, trauma is a sense of I'm overwhelmed to the point where I believe that I might not be able to make it, or I might die, or my bodily integrity is going to be harmed in such a sufficient way that I don't know if I can recover. So that's the DSM-5 definition. So you can be directly exposed to the traumatic thing. You can witness it, like witnessing someone dying. You can learn of it, kind of third hand, and be so overwhelmed by it, etc. Then we have more the relational trauma definition, according to people like Alan Shore over at UCLA, Dan Siegel, etc. And their focus is more on the quality of the experience, in the sense that you don't necessarily have to have experienced physical violence or something that is directly threatening and overwhelming. There's also this second category of stimuli that is traumatic, according to relational psychology, relational trauma, according to Alan Shore in his seminal works. And it's this quality of severe absence of care to the point where we feel overwhelmed or threatened, that we might not survive. So the easy example is if you take a little infant and you were to not pay attention to them, let's say it's like a 1-year-old infant, roughly, and you were to not talk to it, play with it, or feed it for an extended period of time, well beyond what it could handle, something like half a day or a day, where it's just crying endlessly and sobbing itself until it passes out and then doesn't have enough energy to keep up anymore. That is traumatic, because although there's no physical aggressive tiger running at the infant, there is this such dramatic lack of care that it will die if it doesn't receive care. And we are biologically programmed from birth to feel connected to people, because we need to. As mammals, we need some kind of more powerful, older, caretaking creature to keep us alive until we gain some sense of bodily and psychological agency, like 3 or 4 or 5. And even then, we're still kind of helpless. So the relational trauma definition includes physical aggression, like the DSM-5 definition does, but it also includes a psychological sense of I am so uncared for that my life is at stake. And this can happen to young children, it can happen to adults, it can happen to all sorts of people. But it's different, and the DSM doesn't include anything like that. It doesn't include severe neglect. It doesn't include chronic neglect as traumatic. It doesn't include severe attachment failures as traumatic. So depending upon what you do for a living, and depending upon the people you know, it might be worth thinking about the relational trauma definition. But basically, at the core of it, looking at both definitions, trauma is essentially a sense of being so overwhelmed internally and or externally by an experience that we don't think we can handle it. There is no way of handling it, and we cannot process it on our own. Right? Because we can be overwhelmed but process things on our own. So like, you can almost get hit by a car while you're driving and handle that. That's not unmanageable in terms of the feelings. You might be overwhelmed for 5 minutes and pissed off, but you'll be able to process that and go, oh, I'm okay, I'm safe, nothing bad's going to happen, I'm not in the car anymore, everything is okay, right? So that's an example of being overwhelmed, of being able to handle it on your own with your own resources. However, depending upon genetics, life experience, etc., certain things might be so overwhelming that you can't handle them. And in that case, they might be traumatic for you. So that's one way of looking at trauma, as the experience of being overwhelmed to the point where we think our bodily integrity, our emotional integrity, our existential integrity is at risk. And that if nothing is done, we will not make it. Therefore, we are overwhelmed to the point where we have to do something. Fight, flight, or freeze. Typically. So, definitions aside, what does the research say? Like I said earlier, there's a difference between being exposed to a trauma versus developing PTSD or developmental trauma disorder, Bessel van der Kolk, or any of those kinds of things. So for instance, One, what they call epidemiological study, found that the prevalence of PTSD, is a literature review, decreases for most people at roughly 1 month after a trauma. So, within the first month of being traumatized, about 28% of the population, 29, will show diagnosable symptoms of PTSD, whereas about 1 month after that, about 17% will. I'm sorry, about a year after that, about 17% will, which means that roughly a year after being exposed to a trauma, 17% of the population might have PTSD, might have a trauma disorder. However, if you break down what kind of trauma it is in the literature, based upon is it an intentional traumatic experience or non-intentional, it changes. So intentional trauma, people who are assaulted intentionally, for instance, their chances of developing some kind of PTSD at a year later actually goes up from about 12% to about 23%. Whereas people who were unintentionally traumatized, a car accident, unintentional loss, etc., it goes down. And in another analysis, they found that something like 37% of people who are exposed to intentional trauma, who are intentionally assaulted, etc., will develop PTSD. Whereas most of those, about a third, will kind of naturally heal in about 3 months. Roughly 40% of people with PTSD have a chronic course where it slowly kind of goes down over time, even with intervention, that kind of thing. Another study found that roughly 36% of adolescents reported experiencing a trauma. So at least 36% of the teenage population in the United States has been traumatized, is what that study shows. And another study found that roughly PTSD is prevalent at any given time in 4% of the population and 48% of the prison population. 70% of prisoners report childhood sexual trauma. Something like 70% of women, 50% of men, childhood sexual trauma in prison. That's pretty astounding, right? Other research shows that sexual trauma in the military is roughly something like 15% of women and 0.7% of men. Sexual abuse in the military. I think those numbers are probably underreported, but it's just good to know. It's good to know what the actual chance of having a trauma is. So we're approaching 30 to 40% of the population will experience some kind of trauma. Not by chance. We're approaching chance. That's pretty interesting. Probably also underreported, depending upon which definition of trauma you're using. So I hope these numbers make sense. The chance of experiencing a trauma is pretty good. Now the chance of developing PTSD, kind of smaller, which is good. We're resilient individuals. Another kind of interesting finding is that even if you do develop PTSD, you're likely to be able to naturally heal with your psychosocial supports, friends, family, coping skills, habits, hobbies, work environment, etc., to the point where the majority of people who develop PTSD symptoms in the first month will actually kind of not maintain that level of symptomatology. Not that they don't need help, but that they won't be diagnosable within about a year. So that's interesting. So here's some other correlations that I think you all should know that would be useful. And this is stuff that I see all the time in my practice working with clients. Childhood trauma is highly correlated with the development of personality disorders. So narcissism, pathological borderline traits, pathological dependency, pathological histrionic traits are typically correlated with some types of childhood trauma. Multiple traumas in childhood is highly correlated with a a greater prevalence of mood disorders, bipolar and depression in particular. Bipolar 1, that is. Childhood trauma is highly correlated with attachment insecurity, like 0.4, 0.5, 0.6, depending upon what studies you're reading. Highly correlated. Childhood trauma is highly correlated with disruptive behavior. So kids who are traumatized often act out in aggressive or antisocial ways. Not that they have antisocial personality, they just act out in antisocial ways because they're dysregulated. Childhood trauma is highly correlated with self-harm behavior, and it's highly correlated with suicidality in teens, so suicidal ideation, and adults too. Childhood trauma is highly correlated with the risk of psychotic symptoms in childhood. Childhood and adult trauma is highly correlated with substance use disorder. So here's the easy example. If you look at the veteran population in this country, highly important group of people, we should all be very thankful for them. They do a lot to protect us and take care of us. This group of people is putting themselves in harm's way, being trained for it, but still in ridiculous life-threatening circumstances. It's no surprise that the vast majority of them experience some kind of trauma while they're out there serving, and it's no surprise that ridiculous percentages of people who come back from military service come back with PTSD and comorbid substance use disorders, because substances help us cope. Maladaptively, but they help. Here's another great statistic that everyone should know. Something like 60 or 70% of people who have early onset in childhood interpersonal trauma, so abuse, sexual assault, molestation, etc., multiple times, have an egregious proportion, it's like 10 times greater chance of having serious affect dysregulation, mood disorders, etc., compared to people who have a single event trauma. So one trauma, one nasty car accident, etc. It's important because the people that you know in the world might say, yeah, I got hit by a car once and it was pretty traumatic, or yeah, I was beat as a kid, but I've learned to overcome that. I was beat as a kid is a very interesting statement, because that could mean, yeah, one time my dad hit me, or my mom yelled at me and smacked me, or it could mean that I got beat every day. Now, those are multiple traumas. That's what we call chronic interpersonal trauma. And that creates a very different brain and a very different set of mood issues compared to someone who was assaulted one time in their life. Not saying that one's worse than the other, but it just has different consequences according to the research. Adult trauma, highly correlated with substance abuse. Adult trauma is highly correlated with relationship difficulties, romantic relationship issues. People with eating disorders have a greater chance of having a history of multiple traumas. And the more traumas you have, typically, the worse your symptoms of an eating disorder are, according to the research. Binging, purging, anorexia, bulimia, etc. People who are traumatized show very different patterns of emotional reactivity based upon how much trauma they have experienced. So someone who had one life-threatening event shows emotional hyperreactivity and some numbing, typical symptoms of PTSD, compared to people who have multiple traumas. They have an easy startle response more often, and they have greater emotional arousal, generally speaking, but they're more blunted in their startle response. So like, they will notice that they feel unsafe, but they're not going to show it, as it were. And they're not going to consciously experience it in the same visceral, overwhelming, I'm having a panic attack kind of way. So basically, people who are traumatized once, the research shows, they were more likely to have a very strong negative visceral reaction that's hyper exaggerated, compared to people who have multiple traumas having more blunted but still noticeable hyperreactivity to people or startle response. So depending upon how much trauma you experience, you might develop different kind of presentations of the same feeling of overwhelm, as it were. So in the PTSD world, in the trauma world, there are kind of three clusters of symptoms that we experience when we're traumatized. So we experience some kind of reliving issue, like nightmares, having flashbacks, etc. We experience affect dysregulation, so like hypervigilance, very sensitive startle response, very sensitive mood, having extreme anxiety, feeling like you have an itchy trigger finger, being very irritable, chronically irritable, unmanageably irritable, things like that. And then the third category is behavioral avoidance, basically. So we have a desire to avoid overwhelming things. So they live very kind of paranoid, sketchy looking lifestyles where I don't want to be around this kind of person. I don't want to be around this kind of place. And if you take them around that kind of place or person that's triggering them, as it were, they will become rather irritable and rather defensive rather quickly because they feel as if they're going to experience some kind of traumatic emotional reliving, which is reasonable, as we'll talk about here. So next is trauma in the brain. So depending upon when you're traumatized, that's going to dictate how your brain handles it. Because our brain is, like I said earlier, very resilient, which is cool. It's cool that we have this evolutionarily designed apparatus for managing strong negative feelings. The problem is it's not perfect. Therefore, it's designed to be overwhelmed. It's designed to have some upper limit of emotions that it can tolerate so that we learn from that experience and then try to not ever be in it again because we don't want to feel that bad or threatened or at risk again. So our brain's a big learning machine. So what Alan Shore and all the relational trauma people like Bessel van der Kolk talk about is our right brain in childhood is very, very sensitive and developing in the first few years of life. So if we're traumatized in the first, let's say, 4 years, in terms of chronic severe neglect, being in a very loud, like let's say you're a 2-year-old and all that happens when your parents get home from work is they yell at each other intensely and then they come try and take care of you. That yelling can be traumatic for a little kid because they don't know what the hell is going on. They just know loud, angry people don't know if they're going to be there for me. So if that happens chronically, that can be traumatic. And that can actually hamper right brain development and hampers areas around our orbital frontal cortex, our anterior cingulate, these areas designed to help regulate feelings. They can become dysregulated to the point where they either shrivel up and don't grow as many neurons or as much white matter, or they don't actually develop enough wiring from top to bottom to actually turn us off when we're feeling overwhelmed, so we become easily dysregulated. So we become numb or we become easily dysregulated, or both, depending upon the type of trauma. So as adults, what does trauma look like in the brain? So assuming that maybe you've not had a whole lot of childhood trauma, basically hypervigilance looks like our amygdala being so overwhelmed that it's on fire in a brain scan, and it hijacks our frontal cortex. So it's so active that it overpowers our frontal cortex, our ventral medial prefrontal cortex. And we have an underactivation of our anterior cingulate and our parahippocampal gyrus, which means we're not putting the brakes on and calming ourselves down, which means we're not reintegrating memory and completing the loop. And this leads to basically a feeling of overwhelm and overload. Then when it comes to, let's say, dissociation. So we have an overactive amygdala, insula, thalamus. So people who are dissociating, so like, I'm so overwhelmed that I have to numb out right now. This is your brain talking. I'm so overwhelmed, I have to numb out right now, not feel things, and then also not kind of be in my body, dissociate, or not think, or not be present. That's your amygdala talking to your insula, talking to your thalamus, saying, let's not be here. I'm so overwhelmed, I can't handle being consciously present. So our consciousness kind of takes a break for a second. We have underactivation of our frontal circuits and our default network, as it's called, when we're dissociating. And basically, one of the correlations I said earlier is that trauma is highly correlated with personality disorders. So the more trauma you have, the worse your personality disorder symptomatology is. So a lot of research is done on borderline personality. And the more trauma you have, the worse your BPD symptoms are, basically. Avoidance behavior, what does that look like in the brain? So it looks like the hyperactivation of our anterior cingulate for putting the brakes on and saying, go away. The deactivating the opiate system. I feel unsafe, run, go away. Increased activation of our orbital frontal area and parts of our dopamine system for motivation to get up and go and leave in our amygdala. The problem with trauma specifically is that chronic trauma actually kills the brain-derived neurotrophic factor. So if we're constantly exposed to chronic stress, our BDNF levels, our brain fertilizer, goes down, which means we can't learn as well, which means we can't develop new neuronal connections as well, which means we can't reintegrate the memory in such a way that we feel safe, and our current state of mind is, I'm okay. We're stuck in that old way of being. And again, all the research shows that chronic stress, whether it's PTSD, trauma, anxiety, chronic stress leads to increased cortisol, which leads to literally the deterioration of our hippocampus, which means we can't remember, which means we can't learn, which means we can't create new memories as well. It takes a lot more effort, a lot more active healing efforts. So what we have to figure out how to do, basically, is we have to figure out how to turn our amygdala off some. We have to learn how to turn our insula off some. We have to learn how to reactivate our kind of frontal cortex a little bit more. And to do that, here are some tricks. So Pat Ogden and other people, Bessel van der Kolk, Peter Levine, they all talk about somatic therapy. Basically what happens is our brain is kind of synchronously in tune with our body. So if we're experiencing tension in our body, it's related to some kind of emotional anxiety, if you want to call it that. And if you have PTSD, you have this dissociation from your body, especially if you have sexual trauma or physical trauma. So one of the things we want to do is reintegrate the brain with the body and make it okay that the two are emotionally connected with each other. So somatic therapy is a very, very good thing for that. There's some research that shows that's very helpful. Because again, the brain disconnect from our physical sensations is problematic because we're designed to be integrated and to feel both physically and emotionally at the same time and take in the information at the same time to make decisions. But if we experience trauma, we're actually disintegrated. We are not connected. So somatic therapy is very good for that. There's some research that shows that art therapy is good for symptoms like extreme anxiety and extreme depression seen in trauma. So basically the kind of creative effort of drawing, coloring, making pottery, etc., art, allows our brain to be creative, which activates frontal cortex stuff. It activates parietal cortex stuff. It activates the cannabinoid system. It activates the opiate system, all this which calms us down and helps us cope. So art therapy is not good for like doing the tough job of trying to reintegrate the memory in the body and complete the loop, but it's very good for managing the acute symptoms of anxiety, overwhelm, panic, depression, avoidance, fear, startle. To start working on the reliving aspect, the flashbacks, the memories, etc., there are different things we can do. So first, we want to kind of rework or reintegrate that traumatic memory into our current self-understanding. So I was traumatized at the age of 12. I'm currently 46. I need to take that 12-year-old memory, make it mean something, put it in a context, put it in a state of mind, understand the feelings, acknowledge the feelings, and then integrate that into I'm currently 46 and I'm currently okay. Broadly speaking, it's really not that simple, but that's the gross oversimplification. So one phrase that a theorist used to describe it is updating a trauma memory. So that you can rewrite a trauma narrative, you can actually detail out everything that happened to you and rewrite it in such a way that, and speak it into existence, as it were, speak the truth into existence, Jordan Peterson, as I'm okay right now. This happened to me then, but I'm okay right now. But you do this while you're not in the process of actively reliving. If you're currently hypervigilant and reliving a memory that's traumatic, you can't do that kind of work. You just have to cope first and then do that kind of work. So we use exposure therapy. We slowly expose you to increasingly more negative emotional experiences, memories, etc., to the point where you get to the most overwhelming thing, and then you feel better. And then we kind of reintegrate it and we kind of extinguish the fear response. That's something you can only really do in therapy effectively. So basically, we have two goals for traumatic reliving. We manage the symptoms better when they're happening. The hypervigilance, the feeling of overwhelmed, I can't handle it, I'm helpless, I'm out of control. That's one thing we have to do. The second thing we have to do is rewrite the memory. So either we add more context to what happened and why, and then we bring it into the context of the here and now. So that was then, this is now. I'm okay now, I wasn't then. Very broad, very oversimplified, not easy to do. And the last thing that happens is people with PTSD or just trauma in general, just you don't have to have PTSD to have nightmares about bad things that happen. We have to figure out how to manage those better because there's some things we can do. And it's an unfortunate symptom that we don't actually have to have, at least as intensely as we have it. So you can do what's called image rehearsal therapy. So you kind of rehearse the negative nightmare, or the nightmare, I mean, sorry, no, they're all negative, I guess. We rehearse it in broad daylight, maybe in a therapy session or with a friend, and then act out or talk out how to manage it and overcome that negative memory, that nightmare. You can do CBT, you can work on sleep hygiene, you can try certain kinds of antipsychotics. Atypical antipsychotics are decent for nightmares. I'm not a psychiatrist, I'm not a physician, so this is not me telling you what to do, but this is what the research says. So atypical antipsychotics like olanzapine and risperidol and things like that help. Clonidine is a blood pressure med. It helps with managing the symptoms of feeling overwhelmed at night. There are other meds you can try, tricyclic antidepressants. There are different meds. There's a list of meds that can help managing sleep overwhelm that help you manage the nightmares. But basically, that's kind of it for nightmares. Sleep hygiene, image rehearsal therapy, some try to make sense of the memory that is causing you to have a nightmare, and then meds. Those are kind of the 5 things you can do. So this is trauma in a nutshell. There's just so much to say. I mean, my little list of citations here is something like 30 or 40 or whatever. There are hundreds, if not thousands, of articles on trauma and PTSD. At any time, if you would like to talk about this more, I will. I see that a couple of you have commented. Christopher, thank you so much. I will be happy to talk about EMDR. Next time, I don't have the space for that now because there's just so much going on, but I wanted to give everyone a basic overview. So I will put that on the list of, let's call them new therapies, things like EMDR. And I'll talk about its validity, what the research says, the neuroscience behind it. But for now, we know kind of what trauma is. It's the state of being so overwhelmed that our bodily integrity is not going to survive, and or our relationships are so disconnected that we are going to be left alone and die, right? That's trauma in a nutshell. There's a lot of fighting in the professional world about that. There's a lot of brain dysregulation. So people with PTSD, people who have been traumatized who don't have PTSD, are experiencing legitimate brain pathology, brain dysfunction. That is not what a normal person, whatever that means, statistically speaking, would have. So they're more sensitive. And you have to understand that anyone that you know, or if you yourself have trauma, you are more sensitive, or that person is more sensitive to memories and feelings and thoughts that are similar to what happened to that person when they were traumatized. Anything that's similar will trigger them more greatly than a regular person who's not been traumatized. Secondarily, the concept of helplessness. When people are triggered by a trauma memory, they will feel helpless in the moment. That doesn't necessarily mean that they are helpless. It means they feel helpless. So the best thing we can do as a friend, a lover, a therapist, a doctor, a pastor, whatever, is to acknowledge that they feel helpless in the here and now, but that it doesn't actually mean that they are helpless. We need to get them grounded in reality. That doesn't mean talking down to them. That doesn't mean babying them. That doesn't mean being cruel or nasty. That just means saying, hey, I see that you feel helpless and overwhelmed. You don't have to feel helpless and overwhelmed. I'm with you right now. You're okay. You can handle this experience. It's okay that you feel helpless. This makes sense based upon what you went through as a kid. It's okay to feel helpless. Helpless is just fine. This is what happens in trauma. When we are traumatized, we feel helpless in that moment. And then as we get older and live our lives, similar experiences are going to happen that will bring up those traumatic memories. And then our brain will go, oh shit, same thing's happening. Time to feel helpless and overwhelmed and out of control. So what we can do is acknowledge that we feel helpless, and that's okay. And then after that acknowledgement, we move on and we say, what can we do to feel better? Or we try to help the person who's feeling helpless and go, it's okay that you feel helpless. Let's do something right now to feel better. You are not bad for feeling helpless. And you're not helpless. You just feel helpless. And you will be okay, right? So that's really hard to do. It's hard to sit with someone who's having a flashback. It's hard to sit with someone who's freaking out and overwhelmed. But it's worthwhile, because the more we can be a calming influence on those people, the better it'll go. The more we can just acknowledge the fact that they feel helpless and help differentiate the fact that they feel helpless does not mean that they are helpless. Because yeah, when we're being assaulted, molested, abused, shot at, yelled at to the point where we're going to be disconnected from and we're going to die, we do feel like we're helpless. But when that memory comes up 10 years later, or 5 years later, or at the restaurant, or at treatment, you're not helpless. You have a sense of power and agency, and we need to be reminded of that in a loving, compassionate, but stern way. So I hope all this makes sense. I really appreciate you all coming out to take a look at all this. I'm going to post this on Patreon here in a minute. I'm going to post all the research that supports what I'm saying here in a minute. And I hope you have a good rest of your Sunday, a good Father's Day, whatever that means to you. I don't care about holidays, but some of you do. And I will see you again in 2 weeks. Have a good day.